Hey, welcome. My name is Dr. Ngozi Onoha. I'm the founder of Health for Naija. I provide health education content to improve knowledge gaps and to change the health narrative. And today I have with me Dr. Adewumi of Quinta Health. Thank you so much for your patience, Dr. Adewumi. Welcome.
Thank you so much for having me. Good evening from here.
Thank you. We tried to do a live on YouTube, but for some reason, there's some kind of technical malfunction. So the main reason I invited you to speak is because of a tweet where you mentioned that you mentioned something about uterine rupture, and I thought that was really interesting. And then later on, one of the newspapers did a write-up of which you contributed some information. So I really wanted to hear more about it because this is a very rare condition, basically where the uterus just bursts. And
yes.
So I wanted to hear about a little bit more about this condition. And but before we jump in, I know you are the founder of Quinta Health.
Yes.
And you do a lot of work in advocacy and preventive health for women's healthcare. So tell us a bit about what you do.
Okay, Quinta Health is a health service organization. It's an NGO where we focus on female sexual and reproductive health, especially advocacy and screening of women against breast and cervical cancer. We also provide vaccination services to women against HPV, and we started this 5 years ago, and we've been able to screen about 8,000 women for both breast and cervical cancer, and we've been able to treat about 450 women for cervical dysplasia, and we've been able to train more than 120 nurses and medical students on how to screen women for both breast and cervical cancer. So in summary, that is what we do at Quinta Health.
Okay, and is this something you do all over Nigeria, or are you just in one location?
Oh, no, we have been to almost all the geopolitical zones of Nigeria to do the screening. We've not been to just two. We've not been to the south and the northwestern part of Nigeria, but we've been to every other part of Nigeria, in the southwest, in the southeast, in the southwest, southeast, north central. We've been to the northeast too, where we train. Everywhere we go, we train health workers, we screen women, and we treat women for cervical dysplasia. So we've been to well over 18 states in Nigeria to screen women for both breast and cervical cancer.
That's really good. So let's dive into this topic of uterine rupture. It's quite a scary condition, and it's not common. It's quite rare. But in your tweet, you mentioned you had seen 4 people coming with uterine rupture. So can you tell me what it is and who gets it? Who gets uterine? Whose uterus might rupture? Who are the people at risk?
Okay, so when we're talking about uterine rupture, I'll try to just use layman's language. Is a situation whereby the uterus, that is the womb of a woman, bursts, and the burst happens in some rare conditions. And like you mentioned, in developed countries where things work, where there's regulation, it's a very rare condition. Like in the US, for instance, it's just about 1% of women that have uterine rupture. And it's not supposed to happen because it's something that can actually be prevented. But we tend to see it a lot in our practice down here because there is no regulation, and a lot of women do things because of the influence they have from maybe their religious leaders, or maybe from their family, or maybe from people that they've heard things about. So let me just say the common cause of uterine rupture is when a woman wants to try to give birth after a surgery has been done on her womb. So there are two common surgeries that are done on the womb. One is CS, which is cesarean section, and the other is myomectomy, which involves removal of fibroids.
Okay, I think Dr. Adewumi's audio is in and out. So the uterine rupture, the main risks that predispose women to uterine rupture, cesarean section, and women who've had fibroid surgery. So that means there's a scar. Surgery. Yeah, sorry, Dr. Adewumi, you were kind of in and out, so you can continue.
Okay, so there's this scar. There's a scar on the womb, and this scar, when a woman has this scar, sorry, can you hear me?
Yes, I can hear you now. Yes.
Okay. Yes, care has to be taken for the woman not to rupture, and this is what causes the rupture. Because there's this scar on the womb already, you have to supervise the delivery of that woman. The woman cannot deliver again by herself, unsupervised. Now, I have to repeat that again. So we have something that we call VBAC. It is called vaginal birth after cesarean section. VBAC, vaginal birth after cesarean section. It is criminal for a woman to actually do a VBAC in a place where there is no services for CS, such that when that woman gets back to the place to deliver and they try a vaginal delivery for her and it is not successful, immediately they rush her into the theater and do an emergency or an urgent cesarean section for that particular woman. But the reason why we see a lot of uterine rupture in our environment here is that these women go, after a cesarean section, they now go back to maybe a faith home or a traditional birth attendant that they want to give birth by themselves. So they feel that if they come to the hospital, it's an automatic CS for them. No, it's not an automatic CS, especially when the cause of the cesarean section is not a recurrent cause. So there are some things that we call recurrent causes of cesarean section. So if that thing that is causing this, that made the woman to do the cesarean section is not something that is recurrent, meaning that maybe it is not, if she's a very short woman, for instance, now, there's no way she'll be able to deliver by herself. If her pelvis is contracted, there's no way she'll be able to deliver by herself. If she has maybe gestational diabetes, or she has a condition that she must to do CS, then she will have to do the CS for the next delivery. But if it was just maybe fetal distress, like the child was tired or the mother was exhausted, or it was just something that made them to do that CS at that particular point in time, and that thing is not recurring in the next pregnancy, she can give birth by herself. So for any woman who has done CS before in the past, it's important that she delivers in a hospital. And if she does not deliver in the hospital, the possibility of her having a uterine rupture is actually high, because there's already a scar on the uterus, and the moment you do not watch out this scar and you now allow the woman to go to a hospital and try to push out the baby by herself again, then she can have a uterine rupture. Her womb can burst. And most of the times when the womb bursts, there's blood in the stomach. That is what we call the abdomen. The baby is inside this abdomen. The mother loses blood, the baby dies, and it becomes like a double jeopardy at the end of the day. So it's very important that women note that yes, after a CS you can deliver by yourself, but you have to deliver in a hospital. I've known women who had the first CS, but eventually delivered babies. Several women who have delivered babies by themselves. But they didn't do this outside the hospital. They did it in the hospital where there are specialists. And it's not all hospitals. So for that kind of woman, the least kind of hospital that she can be in to give birth to her child is a secondary care center. she cannot go to a primary care center where there's no services of cesarean section or specialist to take care of her. So for any woman who has had a CS before, she has to go to either a general hospital or a teaching hospital, a federal medical center, or a private hospital that has specialists to actually deliver her children.
Okay, this is very enlightening. So I think education is important here, especially getting the word out to women, that especially women who have had any kind of instrumentation on their uterus, who've had, say, for instance, mammectomy, removal of fibroids, cesarean section. No, when fibroids are removed, they create a defect in the uterus, and then that defect is sutured, is stitched up, but it's not as strong as the original uterine wall. So women who had mammectomies, a lot of them, the doctors, the surgeons will tell them that they cannot go into labor, so they should not go into labor. So most of those women, they deliver with cesarean section. So that is important because, if in a place like Nigeria, if a woman presents with uterine rupture, if the services are not available for immediate C-section, then the woman and the child are going to die. So the mortality is high. And so, we talked about uterine rupture. We talked about who gets it. Women who've had previous surgeries, women who've had, multiple pregnancies, carried multiple births, had multiple babies, and those who have multiple pregnancies, twins or triplets. But can you tell me what can we do about, if a uterine rupture occurs, what can we do about it? You mentioned that the women who are at high risk should deliver in a facility that has access to emergency cesarean section, right?
Yes.
So give us some more insight about that, and how can we prevent these things happening? How do we educate women to make sure that they are fully aware of what their options are when it comes to delivery and what their risk factors are? And also look at the point of view of economics. How many people can afford to have their babies in specialist hospitals that have doctors who can do emergency cesarean section? That's another thing we have to look at, the economics, right?
Okay. So I used to work in a village hospital before I started my residency, and in that village hospital, cesarean section was about 36,000 naira. That was the cost, and this was not like, well, let me say probably like some five years ago that I was working in that particular place. And as cheap as the cesarean section was, we still had people coming in with uterine rupture. And that's not because the service is not available or is very expensive, but it's because most of the women want to deliver like Hebrew women, in quotes. A lot of people have this mentality of, anybody who delivers with a CS is not a complete woman. And I like to tell people that CS is actually even safer than vaginal delivery because it's actually a controlled environment. You can control everything that is happening while you are doing a cesarean section for a woman, but you cannot control what happens most of the time when you are doing a vaginal delivery because things can actually go south in both places. But with a cesarean section, you're actually safer. I've seen doctors who have opted for cesarean sections that don't want to go into labor. They just want to give birth to their children by themselves and all that. So having said that, I also understand the fact that there's a lot of poverty in the land and a lot of people cannot afford this. But that is where education comes in. We have to first educate our people for birth preparedness. A lot of people don't prepare for pregnancies. Pregnancies just happen to them in this part of the world. So I think that is one of the things that we need to educate people. They have to plan their family. So if you cannot give birth to a child right now and you have done a cesarean section in the past, I think people should know that, okay, there are options of contraception available to them. You can do contraception, you can do family planning, and then plan your child towards when you are going to deliver. So every woman who is going to have, for instance, now a C-section after the next one should be educated on adequate contraception, have your babies, space them, and then gather the money for you to be able to do your next CS. Because if you say you don't have the money and then you kill yourself, it still does not solve the problem of the poverty or any other thing that is on ground. The second thing that we need to do again is to ensure that traditional birth attendants are either trained. Gynecologists will frown at training them, but I would say as a public health person that they should be trained, because we have dwindling manpower in the health sector every day, and more and more people are patronizing these people because they relate more to the community. They have more interactions with the community. So I feel they should be trained, and if they are not trained, they should be regulated and punished when they churn out cases like uterine rupture to the environment. So I feel that if there's a legislation that bars them from doing some of these things, then it will be easier to take them to court. But what we find is that most families don't want to take cases to court because of the long court processes, because they don't have money. Somebody who could not even do a CS in the first place, would that person have money to go to court and to prosecute a case? No, the person wouldn't have that money. So that's another challenge, because a lot of people would not want to prosecute, because if we have had somebody who has been prosecuted, then we probably will not be having this kind of issues that we are having right now. So I think another thing we can do again is to talk to the traditional leaders and the religious leaders. They should also be educated to know that this giving birth via CS does not make a woman less of a woman. So if a woman definitely knows that if she gives birth via CS, she's not going to be stigmatized in the society, then those who know about it and still go ahead to do it would not go ahead to do it. So I think more awareness, legislation, and health insurance. Health insurance is like very, very important. If people have health insurance and they know that I can walk into the hospital and give birth at any time without paying out of my pockets, people will definitely go to the hospital. And there are health insurances available, but it's just that there's no adequate education, because the federal government has said it is a crime right now for anybody in Nigeria not to have health insurance. So it's very important that we explore these options, and that would adequately solve the problem and probably even bring it to a halt.
Okay. Thank you so much. I've learned a lot. So take-home point is to prevent uterine rupture, provide education on birth preparedness, train traditional birth attendants, and educate community leaders, so as well as legislation. Yeah. So this was really good. Continue with your public health work, and we'll continue on our end and continue to talk to women's groups to educate women about the risks, how to mitigate the risks, how to prevent uterine rupture, how to seek safe care during labor and delivery. So thank you so much. Did you have any other comments, or does anyone have any questions?
No, I actually don't have any other comments. I don't know if somebody has a question.
Okay. All right, well, thank you so much, Dr. Adewumi, for your time this evening and for coming to educate us about how to prevent uterine rupture. And I really appreciate your time.